Thank you.
All right, let's see if this, team viewer again.
What happens to you?
I know. Team viewer apparently does not like me. This happens to every one of my talks.
There we go.
Okay. There we go. Okay. So my name is Mike Tallhamer. I'm a physicist here in the Denver area. I work for Centura Health at a number of different facilities. The primary coverage that I have 2 facilities that I primarily cover in Parker, Colorado, and in Denver, Colorado, that has the TrueBeam platforms with Vision RT. Both systems are the newer HD camera systems. And recently, with the purchase of the TrueBeams, there was some discussion within our clinics about what our 4D technology is going to be. I've been using RPM and Philips bellows probably since sometime around 2007. And so the question came up, do we want to continue to integrate our technology and look at what other value there is? Because there was some things that we were unhappy with some of our 4D technology for CT and delivery. And so when we started evaluating our TrueBeams and going with Vision RT for our TrueBeam platforms, there was the question of, should we look at GateCT for our CTs? And so we decided that we were going to take the plunge at our Denver facility with our new TrueBeam, that we were going to integrate everything, and we're going to go with GateCT and see how that was going to work out for us, and then make a future decision on future purchases based on our experiences and some kind of cross-training between our facilities and getting some input from the users, our therapists, our physicists, and see what their thoughts were on this integrated technology. So before we start, I have no conflicts of interest or disclosures. I tell everybody, and nobody ever takes me up on it, if you want to be on this slide, I would be more than happy to take your money. No. I will add that your name right there. You will appear on every one of my talks. So with that being said, if there's no takers, we'll move on into the talk. The need for 4D CT, obviously, many of us have seen talks, some great talks on SBRT from yesterday and then again this morning. 4D CT largely arises from our need to move, or our desire to move, our stereotactic planning to the other extracranial locations within the human body. Unfortunately, we don't have the stability of the cranial vault at other positions within the anatomy, and so we need some way to compensate for patient motion, and that has largely been accomplished throughout the years through 4D CT. 4D CT methods are used to achieve kind of a highly conformal plan, typically done on either a free breathing or some sort of composite image like a average CT that is generated subsequently from our 4D CTs. And the 4D CT allows us to account for induced respiratory motion, but it also picks up some other motion. We've done some studies where we look at abdominal motion. I know John was talking about they're surprised at how much abdominal motion we actually see due to breath, but there's also abdominal motion due to bowel filling and a number of other things, which are on much longer time scales than typical breaths, but you do see some anatomical motion if you start doing 4D studies within the lower abdomen. I wouldn't say that it's overly beneficial to do 4D studies in the lower abdomen, so that's not an endorsement to everyone go do 4D CTs of all your pelvises, but you will see some motion there. And there's been some calypso studies and some number studies showing that there are some other motions like that. The objectives for the talk are mostly to just understand the currently available technologies. I know we've heard from a few individuals using different technologies. I've had the pleasure and the not such a pleasure of using various different technologies. I'll talk about the ones I'm familiar with, and I'll answer questions on those as well. Review how GateCT is utilized in our activities for 4D CT and SBRT at our clinics and the benefits I believe it brings to the process, and subsequent to our decision to replace all of our 4D technologies with GateCT on our CT scanners, and then review any quality management considerations that are associated with GateCT. So when you come to a site visit, typically we walk you around our center and show you things with the madness of the week. Some of you are laughing at me because nobody made it back to our CT on one of the site visits, but this is what our CT scanner looks like at our newest facility. All of our CT suites are basically the same thing. We use Philips big bore CT scanners. Some of them have the 660-pound table, some of them have the standard table, but we use the lap Dorado system to place Isocenter at the time of SIM. The GateCT camera you can see front and center there in that photo right there. We use it for our 4D CTs, obviously, and we use the Stella injectors for our contrasted studies. And so we use Carina ISO to guide our lasers. We don't use the simulation package from LAP, and we also use the as purchased tumor loc that comes on our Philips CT scanners to do the laser placement, but we don't do any virtual simulations in that software package. Some of you were at my talks yesterday. We use the ORFIT system. I am a dyed-in-the-wool ORFIT person. I make no bones about that. We absolutely love the ORFIT system. We standardize all of our mobilization systems to the ORFIT AIO system. We like it because it allows us to do uniform compression on most sites of the body to control breath. It also allows us to mask a patient eyes to thighs. Not recommended to do it all at once, but obviously whatever area of the body you're treating. This is our cranial SRS, head and neck, upper lung SBRT type of setup here. Anything in the upper apex of the lung. There's another mask here that you'll see that's a thoracic mask, but this is a standard head and neck with an open face. Obviously, if we're doing lung SBRT, we don't need to use the open face mask to track the patient. It's more of a comfort slash claustrophobia slash sometimes we treat mildly demented patients that are less than ideal candidates, unfortunately, and this system allows us to service those patients in a safe, effective way without compromising the quality of the treatment. Standard thoracic lung SRT is done through what we call a thoracic mask. It goes basically from the chin down through the neck and the upper chest. It does not go all the way through mid-abdomen, so it allows you to get a very nice GateCT trace, but will allow you to immobilize the patient very efficiently. This is used for arms up type of setups. And so the patient is set up, that's an arm wedge there. This is Mike Tallhamer's attempt to set up a patient, not a therapist, so forgive any inaccuracies in what you're seeing here. This is my interpretation. Some of the therapists are like, oh, what's going on here? But that is the way I would set them up. That made sense to me. But that is typically how we do it. You see the marks on the mask. This is actually one of our lung SBRT patients that finished just a little while ago. But all of our thoracic patients we tried to treat with one of these masks. Also, SBRT of the spine is done this way. And then this is with the pads removed, so not recommended for patient comfort. Locking a patient down in a highly rigid, tight mask to a board without a pad, one, does not allow them to have a very comfortable experience. And two, this is just to kind of show you the base plate of the AIO solution. This is how we index the patient along the board. You can see there's slots for indexing the patient, eyes to thighs, mid-thigh with a leg separator if you choose to do so. But this is a abdominal mask that we use. This is what we consider like a 5-point mask. And you'll see that the top of the mask is rolled down slightly. We use a uniform compression technique when we CT, where we will make the mask over the patient, and then two therapists will hold a cold wet towel that's basically either wet with cold water or ice water solution in a bucket, and then they gently are on either side of the table and do kind of a uniform compression on the mask, which shrinks the mask and actually cools the mask rapidly and allows for a very tight abdominal mask that presses them down into that blue pad. And this you can get away from. You can do active, basically breath control using this compression method, but it doesn't deform the liver for liver SBRT. We saw a great liver SBRT workflow earlier this morning. There's a lot of systems out there that use paddles, and just from our experience, those paddles really deform the anatomy, and if your target is anywhere in that deformation region, you really are flying blind. And so we've gone to this uniform method. This was kind of woke up in the middle of the night and said, hey, why don't we try this? And we've done it, and our physicians have actually loved it. We've actually done some studies using fiducial placed in the liver and actually breath hold techniques for liver as well, and shown that these abdominal compressions using uniform compression doesn't deform the anatomy and also is extremely stable for patients that can't hold their breath. We ideally like to do our liver SBRTs with the breath hold technique that you saw this morning, but when we can't, these masks are a lifesaver. And so that's kind of our immobilization system for CT. And CT is basically a setup for your 4D planning. And when I say 4D planning, I try to always preface this. True 4D planning is still clinically prohibitive. I know some centers, and I've talked to some research centers that are like brute force approach to this, and they will calculate their dose on all 10 phases, and they do a lot of interesting research. I caution people against trying to get a little too crazy on that. 4D CT works really well because we know the position over the course of a breath cycle. It's computationally and staff and personnel and time requirement prohibitive, just simply because there's a lot of work that goes into some of these brute force methods that you sometimes see at Astro and AAPM. They make for great PhD thesis projects, but sometimes they're not so clinically relevant, and you need to be very careful about how you implement those. The reason is there's some new uncertainties that are introduced when you start doing brute force approach. You do have a dose calculation on all your breath cycles, but that's one permutation of a phase-based breath cycle. All of us, at least doing SBRT, have probably noticed if you do phase-based gating on a LINAC, the breath that you get at CT is not always the breath you get during treatment. And unfortunately, in phase-based gating, they don't care. As long as you get all the phases, it'll gate the beam. And so you need to monitor the position of the tumor during delivery with something like fluoro or triggered imaging or whatever, cine imaging if you have that on your LINACs. Even if we were able to accomplish it as we stated, you only have that one phase that you had at the time of CT. You have that one series of phases, so it's not a true representative 4D plan that you can implement day to day. And therefore, the 4D CT's utility is in the planning process, but actually delineating the targets in their 4D position. So you're looking at your ITVs, your ITV to PTV expansions. You also need to look at your critical structures. We always evaluate our critical structures during our 4D CTs as far as the 4D CT positions of critical structures. Good example that you saw this morning is your adrenal mets. They do move around, and so your adrenals are moving. In 4D, sometimes I've noticed some of our physicians who are new to 4D CTs tend to dial in on their targets. They get these great ITVs in the lung and they forget that everything else is moving too, and they don't draw 4D OARs. And your OARs are moving in and out of sometimes the fields that you're designing, and some people just don't even look at those things. And so we pull out our Timmerman constraints, or we pull our TG 101s, and we pat ourselves on the back that yes, we met the constraints, but we didn't actually contour that 4D target. And so you don't know what your doses are unless you're actually looking at your 4D OARs as well. And so 4D CT and what GateCT and some of these other technologies offer you is a way to evaluate not just your target positions, but also your OAR positions. These are the systems that I was able to bring to mind while putting this talk together some time ago. Obviously, GateCT is at the top of the list because that's what we are using right now. Had many years, probably 7-8 years of experience with varying RPM, had some exposure and some unfortunate exposure to the Elekta ABC system just in my career as far as the usage of that. There's BrainLab ExactTrack, they have a 4D solution, Philips Bellows, the Siemens Anzai belt, Calypso beacons, and then there's various solutions for abdominal compression. We've seen a lot of those lately. And actually the SBRT talk from yesterday had a lot of systems what they evaluated, like the Bionic system and those. And so there's quite a few of those solutions out there. They're kind of color-coded on here. Vision RT is a 3D, obviously, surface imaging system. The ones in blue there require putting an apparatus either on or in the patient in the case of beacons, or the Elekta ABC, you're actually putting like spirometry into the patient's mouth and measuring the flow of air to determine cycle. And then the abdominal compressions, they're basically frame-based motion limiting systems. They're not actually 4D systems, but they're actually kind of compression systems to keep 4D from happening. And so there's various systems. These are the systems I'm familiar with. We had the body fix system for many years, didn't use it all that often because it was very prohibitive in many ways. There's some sites that absolutely love this system. And so one of our physicians went on a site visit and was like completely gung-ho about using this, but like many of the stories we have heard, then you try to treat a patient in it and things kind of go out the window at that point. So it's kind of a free-for-all at that point. The Bellows system, obviously we have Philips CT scanners, and RPM systems kind of been the lion's share of what we've done, workhorse solutions that we've had in the past until about 3 years ago when we bought GateCT. These two pictures actually are attributed to this article, this newer article down here from 2014 from Dr. Chetty on accuracy and normal tissue sparing using cutting-edge technologies. I stole those images because back in the day when we were comparing Philips Bellows to RPM, I didn't take a nice reference image for you guys. So they have a nice reference image in that article, and they talk about the comparison of those and the GateCT product. But those are the systems I'm familiar with. The gated systems I'm not a big fan of because we've had a lot of collision issues. We demoed, I believe, the Civco product, the Civco with the gates and the bridges, and at a previous institution that I was at, we had the body fix system. We had lots and lots of collision issues, lots of limiting to do with these technologies. We also had some issues with the 4D CTs just simply because they kind of lock you into a geometry, and some patients, as you'll see later, that are just not candidates for that. And so what does this mean? Certain technologies will obviously be easier to implement than other certain types of technology. The gated systems and vacuums and saran wrap coverings and all that, that's great as long as you look like the models in those pictures. Sometimes you start running into issues when the patient's morphology is less than ideal for that type of system. Along the same lines, patients will be suitable for certain types of setups. Some of our patients are already pulmonary compromised, so an ABC system where you're literally jamming something in their mouth, putting all these apparatuses on them, and all that, they just don't take to that very well. At least that's been our experiences with that type of system. And then the quality management considerations. We're firm believers at our centers, and I am, if those of you who were at my talk yesterday know that I am a statistics freak. Uncertainty is my mortal enemy. And so I really struggle with the idea of compromising a patient's setup so I can get a good 4D CT so that I can then go treat them in a less optimal position. Your CT is your treatment geometry. So if you have to change your treatment geometry to get a good 4D CT to something less optimal than what the physician would like to treat them in, you're sacrificing the quality of the delivery on one end to get a good 4D CT so you can be more accurate during your treatment planning. And so your accuracy kind of flies out the window. That's a kind of a counterintuitive approach that we've been forced into making sometimes, where this candidate is not a very good candidate for 4D, but we need 4D to do a highly accurate treatment, so let's compromise this treatment position so then we can later come back and treat him in that compromised treatment position, but at least we got really good targets. And so you find yourself in this crazy circular argument, and then those of us who do statistics, heads explode, and we get very frustrated with the whole entire process. And so you have to have these quality management considerations in your mind when you're starting to do these types of treatments. What that does mean is that some candidates are good candidates for gating and some are not good candidates for gating. We've all seen patients whose body morphology prevents you from having your system work in the way you like. Everyone who has RPM, I'm sure you've seen the little old man with the very concave chest whose breathing is actually in and out from here, not up and down from here. And then you take 25 minutes to tape a block to that little area, wedge a roll of tape or some folded up, alcohol swabs to get the block to look at the camera correctly, all to get it all done. And as soon as you move the couch, it falls over and you lose your 4D trace. Then you run back in the room and you set it all back up and then cross your fingers and pray that that goes right through the CT scanner again. And you get halfway through your 4D CT and the block falls off again. And, on and on and on. So some candidates are great and some candidates aren't. With certain technology, it's just prohibitive. If you have an extremely large overweight patient and you have a gated bridge system and you can't clip the gates on, that abdominal compression is basically the abdominal compression because the gate fits around their body. That paddle, you don't even need to use the paddle at that point. And so we've had lots of different types of patients where the systems we thought this is the way to go is not the way to go. And then we make a compromise to their setup so that we can get that really accurate 4D CT so we can have our really nice ITVs. So you need to be careful about picking those patients. All of those frustrations led to our evaluation as far as are there things we can do? And so we looked at GateCT as a way to, can we address these types of quality management considerations, get our very nice 4D CTs, limit the work for the therapist, because my therapist, at two of my institutions, my therapist, every time you say, we are going to gate this patient or we would like to do a 4D CT, all of a sudden they've got to go do this or they've got to do that, and this person's in sim this week, and it's a disaster. And I feel for them, because I've been part of a lot of these CT sims. For the longest time, physicists had to be there, so we got to see firsthand the torture that we had to put them through when we said, hey, do a 4D CT, and we got to go back to our office, and then they come back frustrated and ready to pull out the pitchforks and the torches and storm the office. And so I've seen that, and so I kind of have empathy towards that. The quality management review we did, we compared GateCT's performance using similar tests that we've used in the past. I say that because I always preface everything I said. We had much better performance with our GateCT in comparing on TG66 and TG53. We attribute to that. That's why it's bold. The better performance, I think, is because we chose a better phantom. We do an end-to-end test for all of our 4D CTs where we look at geometric reconstruction, we look at positional reconstruction. In this case, we chose the Isocenter cube. We got to cheat because we had the Isocenter phantom from Vision RT because of our Isocenter calibrations that we do for our SRSs. We use that Phantom, and the Phantom has ceramic spheres in it rather than tungsten carbide spheres or stainless steel spheres. And you have some geometric distortion and some reconstruction problems when you're trying to CT that metal ball. All of us physicists who've CT'd Phantoms with metal spheres in them, they never look like metal spheres. When you go back to your CT, they look like an egg or some randomly odd shaped deal. And so when you exacerbate that by using 4D motion and trying to reconstruct with all that artifact, you never get an ideal solution. The Isocenter Cube Phantom from Vision RT is phenomenal for this end-to-end test because there's no artifact, and so you get to use your 4D. We did the first test we used the Isocenter Cube Phantom, put it on a Sun Nuclear Motion Sim, and ran it through, did all the reconstruction, got all the values back, and it was phenomenal. We were blown away. And then we started comparing it to the old one and said, why was the old system bad? And then we started looking at it and thought, maybe it wasn't the old system was worse. It was probably the fact that we were doing it on Phantoms that were less than ideal. And so we did these end-to-end tests to look at our overall quality management system because we wanted some system that would give us equal or better performance, but also didn't introduce all those other ancillary quality management concerns of, are we going to have to change our patient setups to get good 4D CTs to then treat them in a less optimal position. Overall, we had a very positive experience introducing GateCT at our clinic. We introduced it. We did some polling of the therapists who had to go between sites and do these CT sims. A lot of them said the system has a little bit of a steeper learning curve when compared to like the bellows of the RPM because they're very plug and play-ish. Those two systems are very well engineered to make it work well right out of the box, and so it's a very easy system to learn. The GateCT has a few other settings. I think sometimes we kind of get overwhelmed with how many settings we have and all the cool things we can do. You can have tracking points and you can have monitoring points and you can have all kinds of stuff. So when you start giving that to the therapist, where they're used to just tape box to patient, turn on tracking, and everything works out, then you're like, oh, well, you can monitor the shoulder for gross positional movements, and then you can do the trace point and this, and then they're just like, whoa, wait a minute, we just want to do a 4D CT. And so we had an overwhelmingly positive experience, but there was a learning curve that was associated, but everyone who said there was a steeper learning curve immediately turned around and said, we would much rather do this system because there's no in and out of the room. You set up the patient the way you want the patient to be treated, the way the physician has prescribed that patient to be treated. You don't have to compromise the patient's setup in any way. And then from the CT control room, you get to point and click. You click on a tracking point, you track. If you don't have a good trace or the trace is kind of sporadic, you get to actually just hold down control and left click and pick a new point. You don't have to go in the room, move the block, adjust the gain on the camera, turn this dial, do this, shove this in their mouth, turn them this way, put their hips up. You don't have to do any of that stuff. And so the in and out of the room that they completely eliminated with the GateCT was overwhelmingly the positive response that we got back from every therapist without question. The steeper learning curve also, we didn't distinguish between the learning curve for the CT versus the system. We went from GE CTs to Philips CTs kind of at the same time. And if those of you who have done that, there's a very different learning curve between a GE and a Philips. Those of you who've done site visits, you know what I prefer. I won't share that with everybody. But both CT systems are very nice, but the binning systems and the number of other items for a CT system it can play a role in the learning curve with using one of these systems. And so it's not completely evaluated independent of that. So you need to watch when you're evaluating. If you have a CT that you're very familiar with, and you can kind of independently evaluate RPM, bellows, Vision RT, whatever you'd like to put in there. But if you're changing CT platform and changing your gating system, so you have to kind of be very careful to have them distinguish what part of it don't you like. Is it the CT operational console side, or is it the actual performance of the system? And so when we've kind of teased that out in reviewing it with our therapist, it was mostly the CT side that they were having struggles with and not necessarily the GateCT, but overwhelmingly the positive experience led us to basically replace all of our RPMs. We're putting in our third GateCT right now, and then lots of our sites are clamoring for their turn to change to GateCT. And so GateCT has been a big lifesaver as far as I don't get hate mail when we ask for 4D CTs anymore. And so we do more 4D CTs because it's relatively easy and we can check other things when we're doing these types of studies. This is the Isocenter Cube, in case you missed SRS talk yesterday. It's got 5 ceramic spheres. They're known to within a very high degree of precision. You can use this on a 4D capability. You also get what they call the Emily Phantom, and the Emily Phantom is a dress model with a hanger in it. So it's like a store dress model thing. It's like a mannequin, and so One of the other nice things is she's very light compared to the SRS Cube. So if you have an RPM system and you have the variant RPM Phantom, you can rest her on the RPM Phantom and you can give Emily life and breath, which does wonders for your self-esteem, but also helps you do CTQA. You can put her on the CT scanner. She can breathe for you. You can monitor her with GateCT. You can do 4D CTs. The spheres are great because they're known volumes. You know what else is great? Syringes. The flush syringes that have mLs on the side or cc's. You can fill those with various amounts of water, which shows up great on a CT, in case you were wondering. And you can tape them to her surface, and you can do all of your TG66 and all of your TG53 data transfer checks, volumetric checks, and reconstruction checks using Emily breathing with an RPM Phantom. If you have a variant machine, they'll give you one for free. And tape those syringes with different volumes to Emily, allow her to breathe, reconstruct it, measure the volumes, and you've just completely tricked out your 66 QA and your 53 QA in less than 20 minutes. And so they say, a necessity is the mother of invention. I believe it's laziness, because I've got way too little time to do all of that QA, and so I find ways to kind of add them all together. So that's a little trick for me to you. If you have the slides on your drives, the actual procedures and the notes of this slide on how to set this Phantom up for an end-to-end test for CT, they're in there. There's also a 4D CT note on this slide as well if you have them on your jump drives and have access to the notes. The whole procedure for setting this Phantom up is there. The Emily Phantom is not on there, but it's relatively easy. You set up Emily, rest her on an RPM Phantom, let her breathe, throw some syringes on there full of the fluid of your choice, gel, if you have just saline or water, fill them with the different mLs, allow your 4D to reconstruct it on a number of different phase tracking points, measure the volumes, and TG66 and 53 are all satisfied. And then last slide, this is what we believe GateCT has offered to us and our patients. Patients, quick simulation times. There is no more in and out of the room trying to balance that crazy box or put the bellows belt in the right place to get underneath the mask or not on the mask or however we need to do that, and then asking our dosimetrist to forgive us and correct that in planning. So our patients get a nice quick CT. These are kind of roughly the stages of a 4D CT. We actually do exactly what everyone has just said. So yesterday with the free breathing, 4D, and then a breath hold, we do the exact same thing, so it's good to know that we're not totally crazy. We do add a permutation that sometimes we want a contrast study, so we will repeat the free breathing with a contrast or just do the free breathing with a contrast in the case if a physician requests it. And then there's no need to put any apparatus on the patient. So we're not asking the patient to breathe normally while I stick this on you, or breathe normally while I shove this in your mouth. I mean, there's very few things that we do that sometimes make sense to our patients. One of the things that I can say, because of all the breath hold techniques we've talked about, we coach our patients at the time of CT sim for our breath holds and for our gating. One of the things we found is visual feedback in the treatment room or in the CT room tend to overwhelm our patients. You throw an iPad in front of their face, and you throw this, you throw some virtual reality goggles on them, and there's a screen, and you have an 85-year-old woman who's like, what are you doing to me? It's like, welcome to the future. Here we go. And so it's a little bit more difficult to tell them, act normally, breathe normally, and here, we're going to strap this helmet to your head. And it's just like, it's a counterintuitive approach to getting them to be consistent. We have found that we've gotten rid of all of our feedback systems completely. And I went to a kind of a physiology seminar back when I was back in Cleveland at the Cleveland Clinic and talking to one of their pulmonologists. And we tell our patients now, I coach all of our patients and I ask our therapists to coach our patients to say, breathe in through your nose until you naturally stop breathing and then hold your breath. That is the most comfortable, most accurate way to fill your lungs because your lungs have a finite volume. They're not going to get any bigger. They're not getting any smaller. And so we've gone to that, and our breath hold techniques are rock solid. Breath hold liver, breath hold breast. And what you get from that is a very comfortable inhale through the nose, given they don't have hay fever and they've got a stuffy nose or something like that. But you tell them to breathe in through their nose, a deep breath until they naturally stop. And that stop position is almost dead on perfect every single time. And it's because you're using the physiology of their breathing to your advantage. When we tell our patients, we're going to do deep inspiration, breath hold, liver or breast, sometimes we tell them, take a deep breath, and that sounds natural to us. To them, they hear, this is the last breath you are ever going to have. And so they do the deep breath, inhale every bit of oxygen you can, thrust your hips, arch your back, turn your shoulders, and then you get an unbelievably high quality CT. And then you go to delivery and you tell them to do the same thing. Now we're going to do an image, take a deep breath and hold it. And again, they hear over the microphone. I think the TrueBeam mics are probably bad, but this is the last breath you will get for the next hour and 45 minutes. And they're like, I have to get all the oxygen I can possibly get because I'm not getting any more. And so again, a deep breath means pelvic thrust, shoulder turn, arch your back. It's very interesting. And when you have Vision RT and you can watch them do this, it's absolutely kind of hilarious, because you take a deep breath, you're monitoring this little ROI, and you see the rest of the body do one of these numbers, and it's like, I just asked you to breathe normally. And so maybe the mics are bad on our TrueBeams, I'm not really sure, but it alleviates all those things for our patients. We're not strapping things to them, putting goggles on them, doing all these things. It just do your thing. Breathe normally. If I ask you to hold your breath, this is what we mean when we say hold your breath. And when you naturally stop, you're not stretching your muscles out, and you don't see the fade that you normally see if someone takes a really big deep breath and you start seeing them fade through treatment or fade through a CT. So those are just things that we've found over the time that it gives to our patients. Staff, obviously way less dosimetry time we've seen. We're not asking them to contour out belts. If the box is in the treatment field, we're not asking them, okay, make sure you tattoo the 3 corners of the box. Reproducibility is great because the point's saved. Collision considerations, another thing that we like about the Orfit system, we have all those masks. If you get a good 4D CT and you pick your phase that you're going to calc on, you can put an ROI in there. The collision issues that we heard about today are very, very real depending on what system you have. Our system we love because we have the mask. You can put an ROI on the mask. You can actually go set up the mask without the patient, do your couch kicks, do your gantry angles, and if you know you're going to collide, guess what? You just tell your dosimetrist, don't use that couch angle, or don't use that gantry angle, or stop at this gantry angle versus that gantry angle, because we set it up and we can verify, because the ROI doesn't care that the patient's not there. You have the mask in the CT, so it'll set the mask up just like it'll set a patient up. And so we use that quite extensively during dosimetry. Our dosimetrists love it because they're not replanning on the fly. But we know it took you 2 days to do this SBRT. We now need you to do it in 37 seconds because there's a patient here and we need to redo it. And so we don't ask them to do, superhuman things with their planning abilities anymore. We kind of proactively use the system to QA itself. And then the easy interface, determine best tracking points. Again, like we mentioned, we're not going in and out of the room to change apparatus around to get a good tracking point. We're just point and clicking on our patients. Really costs you nothing. You just get to hold down the control button, left mouse click until you found the point you like. A nice stable point preferably, so you get a nice 4D CT. And then selection of different tracking points is very easy, but also editing of the trace. I actually talked to a site visit person the other day. He likes using the Philips interface. I don't like using the Philips interface, but I love using the GateCT interface. I came from a long line of GE scanners, cut my teeth on GE and Advantage Sim. I love how fast it bends, but if you've ever tried to edit a trace in Advantage Sim, much more cumbersome in my opinion than editing in GateCT. So it gives you a nice easy interface to edit your traces. If a patient coughs, does something crazy during CT, if you're using monitoring points and you see a gross move, you can make that decision on how that affected your trace. But the editing in the GateCT product is relatively easy. I should have actually added a slide to that. I apologize for not doing that. But the actual software interface is relatively nice, relatively easy to work with. And so with that, yep, I was correct. That was the last slide. If you have any questions, I'd be happy to answer your questions. We've got about 5-10 minutes.